as I've already explained, this is the last conference at which I'll be attending as chair, and next year you'll be welcomed by a new one. But rather than give some sort of self-serving valedictory address, I want to tell you of my personal hopes, dreams perhaps, for NICE's future. I'll briefly describe my 6 hopes. I've actually 7, but because Mike Kelly will be on the platform shortly, I'll let him talk about public health dreams. Here are my 6 dreams, and I'll expand on each in a moment. I want our clinical guidelines to incorporate multimorbidities or comorbidities and move beyond giving advice on single conditions. I want to see real-time, person-specific decision support systems on every clinician's desktop based on NICE's guidance. I want NICE, in deciding whether products and services are cost-effective, to develop a more quantitative as opposed to qualitative approach to social value judgments. I want to see a more formal system for tracking the uptake of our guidance. I want to see long-term support for the work NICE does in developing countries. And I want there to be alignment between the NHS Commissioning Board, CQC Monitor and NICE for ensuring that the NHS provides continuous improvement in quality. First, Dream 1. I'm very proud of NICE's clinical guidelines. Apart from the direct benefit they bring to patients, they now underpin the quality outcomes framework, the quality standards, not to mention the commissioning outcomes framework that we've already started to publish in draft form. Our clinical guidelines are widely regarded globally as of very high quality. Even in the US, they have an extraordinary following. But there is a problem associated with them which we can't ignore. Our guidelines, like virtually all others, are concerned with the management of single conditions, yet many patients have more than one condition simultaneously. A study published only last week in The Lancet from Bruce Guthrie's group in Dundee demonstrated this in a large Scottish population. For people over the age of 60, half will have 2 concurrent conditions. For those over 70, nearly 50% will have 3 comorbidities. And by the age of 80, nearly half of us can expect to have up to 4. We need to start developing methods that would allow us to provide advice in our guidelines on the management of comorbidities, particularly for chronic conditions. It won't be easy, but that mustn't deter us. The evidence base will be imperfect, and there will be a limit to the number of comorbidities that a particular guideline can incorporate. But our Mental Health Collaborating Centre has already developed a guideline on the management of depression in people with physical illness, and we need to build on this sort of work. Dream 2. Patient-specific, real-time decision support tools are already starting to provide clinicians with advice on how best to manage a particular patient's condition, whether it be in the consulting room or on the ward. These decision support systems are at present in their infancy, but they will become more sophisticated over the next few years. We need to ensure, for the UK anyway, that these systems incorporate NICE guidance, and we've made a start. First, we are digitizing our guidance so that third-party suppliers of decision support software can incorporate our guidance in their product. Secondly, we are developing for NICE pathways that display in algorithmic form the totality of NICE guidance. For the future, these need to be integrated into a patient's electronic medical record so that a clinician can see at a glance at which point in the pathway the patient has reached and what options are available for the future. And NICE's guidance is also available free on an app, suitable for Androids and iPhones, as well as iPads. There's no reason why real-time, patient-specific decision support systems shouldn't be similarly available to patients and their families to use and incorporating NICE guidance. Dream 3, multi-criteria decision analysis. Advisory bodies look at cost-effectiveness. They examine very carefully the most plausible incremental cost-effectiveness ratio, the ISA, expressed as the cost per QALY. Above an ISA of £30,000 per QALY, other factors come into play in deciding whether a particular intervention is appropriate for use in the NHS. These other factors are largely social values, and our advisory bodies have been given advice from the board about the latitude they have in taking these into account. And they do. Here are some of the pharmaceutical products that our advisory bodies have in the past regarded as cost-effective, even as though their ICEs exceeded a £30,000 per collie threshold. They have even gone as far as £65,000 per collie in the case of imatinib, Glyvec, for blast cell phase of chronic myeloid leukemia. In doing so, they have taken social values into account, ones that our Citizens' Council have indicated should play a role, such as the severity of the underlying disease or treatments that extend life at the end of life. This approach is fine, as far as it goes, but it is based on a qualitative rather than a quantitative assessment of the relative significance of these components. I believe we can and should do better. I believe that we should, for at least some of these value judgments, weight the QALY and adjust quantitatively ISA. I don't believe it will be totally remove the need for our advisory bodies to exercise judgment, but it would increase the objectivity and transparency of the way we work and ensure much greater consistency. Dream 4. Monitoring the uptake and use of NICE guidance is important, not just to massage the egos of those who've developed the advice, but also to see how it might be improved and updated, and what other tools might be needed for implementation. We don't at NICE have the resources to do this ourselves, but sometimes others do it for us. Here is an example of such an audit on the use throughout England of antimicrobial prophylaxis by dentists for people with valvular heart disease. As you can see, as a result of NICE's guidance, use has fallen by 85% without any increase in hospital admissions for endocarditis. That, of course, is reassuring, but such audits need to become commonplace. I'm aware that individual trusts do indeed audit aspects of NICE guidance, but a coordinated approach would be much more helpful. Dream 5. There has over the years been an increasing interest and requests for help from middle-income countries. The help they seek is threefold. First, many want help to build capacity for health technology assessment and health economics. Second, some want help in adapting NICE's guidelines to meet their own particular circumstances. And third, a few, Colombia, China and India for example, want to establish their own versions of NICE. About 4 years ago, we established within NICE a small international division to provide help to developing countries. And as you can see here, the range of over 30 countries we've carried out missions are shown. We can't use NICE's grant in aid for this work, because that comes from Parliament's vote for the NHS, and Andrew Dillon and I would be carted off to the tower if we even thought about doing so. Our missions to date have been funded on a project basis, mainly by the World Bank, the Inter-American Development Bank, and the International Monetary Fund, with some additional support from the Department of Health and from DFID. That's okay up to a point, but we really now need some core funding to put NICE International on a secure long-term footing. And finally, my sixth dream. Continuous quality improvements will ultimately rest with the clinical staff of the NHS. But they need help, most particularly to ensure that the environment and infrastructure are supported. The commissioners, the NHS Commissioning Board, the CCGs will clearly play a critical role. So too will CQC and Monitor. But it'll only work if these organisations are aligned in their approaches, their priorities and their goals with NICE guidance. When aligned, we can be very effective. And here is an example. We published a clinical guideline in the spring of 2010 that included an exhortation to all medical and surgical patients to undergo risk assessment for VTE on admission. This shows the monthly data for the NHS as a whole on the proportion of patients admitted to hospital undergoing a VTE assessment between July 2010 and December 2011. The proportion of patients has increased from less than 45% to over 90%. This change isn't just attributable to NICE. VTE assessment also attracted sequin payments, which I'm sure also helped in implementation. Such a joined-up approach to seeking continuous quality improvements needs alignment between NICE, the Commissioning Board, CCGs, as well as CQC and Monitor. Malcolm, myself, and my successor will not disappoint you. Thank you very much.